I would request the participants not to annotate the slides. They are annotating the slides. I think Dr. Archana, don't annotate the slide. Don't scratch the slides because you are making it yellow and blue. Sir, good
अनूप,
evening. Welcome, sir. Yeah, yeah.
हाय अनूप, कैसे है?
All good, sir. All good.
डॉक्टर चंद्रकला इज ऑलरेडी देयर. या
Yeah, she's
Yes,
here.
yes,
या हाय.
yes.
या
Hi, good evening.
हाय, कैसे हैं आप? सो या तो यू कैन जस्ट अभी पीपीटी हटा सकते हैं. आपने देख लिया, आपकी पीपीटी चल रही है ना? योर पीपीटी इज
Mm-hmm.
वर्किंग ना? हाँ,
Yeah, yeah, I've checked, I've checked.
यू कैन, हाँ, यू कैन
I've
स्टॉप,
checked.
यू कैन स्टॉप शेयरिंग फॉर अ व्हाइल, देन जस्ट. एंड सुशांता, अनूप, हाय सर हैं डॉक्टर सिया. कैसे हैं सर? डॉक्टर सिया कैसे रहा? लास्ट टाइम परसों आपका बेटा था सर. ठीक है, आज आप हैं. उदित, उदित was here. किरण, अमरजीत, या अनुपम मैडम, अर्चना, आरिफ, वाला, मनीषा. डॉक्टर से आगे दे रहा. लास्ट टाइम परसों आपका बेटा था सर. मेरी आवाज क्या इको कर रही है क्या?
Yes.
इट्स इकोइंग. अच्छा, अनुप सुशांत करेगा या शेखर?
नहीं सर, मैं वो कर दूंगा. स्टार्ट कर दूंगा मीटिंग. फिर उसके बाद आप कुछ बोलेंगे. फिर हम
Yeah,
डॉक्टर.
that I know, but who is kind to?
आप सर म्यूट पे चले गए हो. विश सर.
Good evening, Dr. Somsekhar. Good
Hi,
evening.
Chandrakala. Good evening. Good
Hi.
evening.
Good evening, sir. Welcome, sir. Very good evening.
So, Anup, I think we should start because it's 7 o'clock.
Okay, sir. I think because he was also, I think Ravi has joined. Dr. Ravi.
I spoke to him. He's going to join, but I think we
Okay,
can start.
okay. Surinder Vish, sir, I'm starting because it's 7 and Dr. Somsekhar has another meeting.
Has Surinder Singh joined?
Yeah, he is joined, ma'am. He is joined. He's already joined. He's there.
All right.
Good evening, ma'am. Welcome, ma'am. Nice to see you.
Good evening.
Hi, Vidya, ma'am. Good evening.
Hi, how are you?
Good.
I'll just give me 1 minute. Surinder, sir, you're there? I'll just call him. Just give me 1 minute.
Yeah.
Okay, so very good evening to all of you, all the dignitaries, members of NNF, all the doctors, residents, clinician, and all the nurses as well. So we have 57 participants, and welcome to all of you to this monthly meet of Delhi NNF Association of Neurologists. And this is the second monthly meet this year, and we are extremely happy and delighted to have with us some of the very eminent speakers and moderators. So it's really great to have Somsekhar sir here, President-elect,
Right.
and for a topic which is on resuscitation, and it is an honor to have someone who is a member of International Liaison Committee who has worked for decades in this particular field. And I'm also extremely pleased to have Chandrakala ma'am here, a national figure as far as NRP is concerned, and she's there on all TOTs. And in fact, in 2019, when I was revising my TOT, she was in Bangalore and she was coordinating the program. So what a wonderful teacher, what a wonderful speaker. So really pleased to have ma'am here as well. And Ravi Sachin, my dear friend and treasurer of NNF, we have a long association, last 15 years. Does wonderful work in resuscitation. And Ravi, we are glad to have you here. So, in the format of the meeting, what I'm going to do is that I'm going to hand over to Dr. Surinder Singh Vist to speak a few words, and then we will start the meeting. Dr. Vist, you have joined.
Thank you, Anup. And I'm really blessed to have you as the person in charge of Association of Neurologists Delhi this year and for the next year as well. Anup has been a great help, great organizer, and because of him, we are able to do. We will be able to conduct lot many of programs. That is so great of you, Anup, and I'm so thankful to my dear friend Dr. Somsekhar Nimbalkar sir, the president-elect 2026. He will be the president 2027 of National Neurology Forum. And I must tell all the audience that he's now headed like Modi ji headed to Delhi. He has headed to Delhi. Now he is in ICMR. He will be joining ICMR, Reproductive and Child Health Division, as the consultant over there. And I thank Dr. Ravi Sachin for having agreed upon this, because he's one of the finest teachers of neonatal resuscitation in Delhi. And when we were talking about NRP updates, so I had two persons in mind, Dr. Lalan Bharti, who is the president. I cannot ask him to speak on this. And the other person is Dr. Chandrakala. So Dr. Chandrakala has been the national coordinator of IAP NRP FGM project. She's still the joint coordinator of IAP NRP FGM, and I'm so glad that she works tirelessly and for NRP, and you can see the St. John's beautiful ground behind her, the lovely college that she is in, the St. John's of Bangalore, and I'm really thankful, Dr. Chandrakala, that you agreed upon to speak on this. Anup.
Thank you, sir. Thank you so much. So I will now hand over to Dr. Shekhar Vishwas, our meeting coordinator, to introduce the chairpersons for the session. And then I would request Dr. Somshekhar also to speak a few words about the liaison committee before we start the presentation. Dr. Shekhar, you're there?
Yeah.
Yeah.
Thank you, Dr. Anup. And I will welcome the chairpersons, Dr. Shomshekar Nimalkar, sir, professor of Parmukh Swami Medical College in Karamsad, Gujarat, India, and Dr. Ravi Sachan, my dear friend and professor, unit in charge, Department of Neurology, UCMS Delhi. So to begin the proceeding, we welcome Dr. Shomshekar to say a few words. Thank you.
Thank you, sir. Thank you, Dr. Besh, Dr. Ravi, and Dr. Anup for inviting me. Pleased to see Dr. Laran also in the meeting. And I would want to share a few things that India has been part of the ILCOR committee since 2023 June. So it's just recently that we have become members. And ILCOR has various verticals. So adult, there are a few verticals, and there's an education vertical. Pediatric, there are now currently two verticals, basic and advanced pediatric life support, and neonatal vertical is one of the other verticals of ILCOR. So they also have verticals on communication, AI, and so on and so forth. So it's kind of a very vertical oriented organization. It's a completely voluntary organization where people travel on their own and stay on their own, except for a few people who get funded. Otherwise, it's an organization which has been working since 1992 onwards, and in a more organized fashion since roughly around 2000 or 2001 onwards. Uh, Despite having the largest number of births, India has not been part of the ILCOR, especially for the neonatal part, as well as even otherwise, population-wise, we have not been part of ILCOR despite having a large population, as has been the case for many international organizations. But because of the efforts of Indian Resuscitation Council Federation, which pursued this since 2017-18, we were able to get into ILCOR, and NNF has agreed to work with IRCF this year, last year, and IAP has been working with IRCF since 2021 or so. So both the neonatal what do you say bodies are working with IRCF. So we are represented in this council by various pediatricians. So there are two pediatricians who are part of the pediatric group, and myself and Veera are part of the neonatal group. There are a few adult physicians also. So roughly around 10 people are 10 to 12 people are there from India in various groups. So it's a very intensive work. A lot of discussion goes around, even in terms of wording of the what do you say documents and so on and so forth. So what you see published this year is actually was approved somewhere in January in 2025. So it takes around 10 months for the entire process to kind of complete also. So I guess I think that's what all I have to add, and I hope that we will be able to produce much more evidence. India has produced a lot of evidence in resuscitation, for instance, room air resuscitation, also in terms of what do you say meconium related changes in the algorithm, as also, and so there are many factors where we have kind of contributed to the evidence build up also. And so it's good to see a lot of papers being published from India in the recent maybe 5 to 6 years in this particular area. And I'm sure Dr. Chandrakala will do an excellent job because we have been working on these updates for the last few months, 3 4 months since the updates came out, and we have a new module. She'll talk about. I'm sure she'll talk about it, and she'll discuss the various updates that have come up. Over to you, Dr. Anup. Thank you, and thank you for letting me go because I was just getting a call for the second
So
meeting.
let me just interrupt Anup just a second, because it is International Liaison Committee on Resuscitation, ILCOR. For those, the younger ones who do not know, this is the major body which makes all the recommendations across the globe for next 5 years or so. Every time they are regularly meeting and doing all these things. And we are so fortunate to have Dr. Somshekhar from India, the only person after so many years who is representing India along with Veera Raghavan. And I'm really thankful to you. Sorry, we could not, I should have remembered that. I was just talking about my friendship with you. Okay, sorry.
Thank you. Chalo.
Yeah,
All right.
Dr. Yeah, thank you, sir. Thank you. Dr. Ravi Sachin, I would request you
Yeah.
to kindly introduce the speaker.
Yeah, I think thank you, Dr. Anu, for a wonderful introduction. And sir has already given a brief background about the neonatal resuscitation, how the evidence generate, and how they come up. So the Dr. Chandkala is not means known, very much familiar known. Barely any person who doesn't know about her. Dr. Chandkala is working in the St. John Medical College, and she is one of the renowned academician who has contributed to evidence-based neonatal care practices, and she has been associated with neonatal resuscitation program quite a long back. I think over a decades of experience. So I think she would justifies, and I think her talk will give you some insight and thoughtful provoking. As far as the recent update is concerned, it is very much pertinent as today's program is concerned. And I think as a clinician, as a day-to-day practitioner, we will have some better understanding after the talk. Over to you, Dr. Chankala.
Yeah, thank you. So I would like to thank the chairpersons, Dr. Somshekhar and Dr. Ravi Sachin, for the warm introduction. I thank Lalan sir, the NNF president, and Dr. Bist is the NNF Delhi president, and Dr. Anup Thakur for the opportunity. And it is a great opportunity for me to present here. Thank you very much. Shall I share my presentation?
Yes,
Yes,
ma'am.
please. Please.
So is it seen? I'm audible?
Yes, yes.
Yes, ma'am.
Yes, yes. Please go ahead. Please go ahead.
Right.
Yeah.
Okay. Yeah. Very good evening, everyone. Thank you, everyone, for being here. I'm sure that I'll do justice for my presentation. And if you have any questions, please put it in the chat box. We can discuss later. So I'm going to discuss the important NRP updates, which has been published recently. So the objective of my presentation goes like this. So all of us know that effective and timely resuscitation at birth improve neonatal outcomes. So the genesis of NRP updates. So this beautiful slide, I thank Dr. Lalan sir for this excellent slide, and I've taken from him. So all of us, it is important for, there may be many juniors here. I want them to know that, we started in 1980, and in the Committee on Fetus and Newborn Perinatology, it made NRP as a mandatory training, and it became official in 1987. So international, that is ILCOR, International Liaison Committee on Resuscitation, it reviews all the evidence available once in 5 years that the National Life Support Task Force, along with the ILCOR Member Resuscitation Council, they update all the, the science, which is, for the last 5 years. And along with it does scope review, systematic review, which is, there are 4 systematic review available, 2 scope review available, along with the evidence updates. It has brought the new guidelines. The ILCOR provides the consensus on science with treatment recommendation, that is COSTAR, that is recent 2026. So it has various bodies, that is, the USAAP, India, Canada, and Europe. So I'm going straight away to the updates. So they're under the main committee. Dr. Bist was saying about the ILCOR. So there are many juniors. I want them to know what is that ILCOR, and it's the biggest body. It's a main committee which initiates the guideline development process. And there are many councils across the globe. Indian Resuscitation Council Federation represent India on ILCOR since 2023. And Dr. Veera and Dr. Somshekhar Nimbalkar are the Indian representatives, and it's really great news for us. And these experts perform systematic literature reviews on key resuscitation topics. They use the GRADE methodology to assess strength of recommendations and the quality of evidence. And this slide just says that there is a lot of work goes behind this, the final COSTAR version for posting and publication. All these are, I'm just open my, okay, okay. So all these, this is a big work which is involved before the publication. So it's not moving.
You are not getting a laser pointer, or it is?
I'm not getting the laser pointer. One second. So it's not moving. Yeah, it's moving now. So it is here. This is an important slide. So whatever I'm just putting it here. So we have to just match this with the class of recommendation along with the the class of recommendation and evidence basis for that recommendation. So it's very important that the class of recommendation level of evidence, which is here. This is the previous slide which I have put it. This is very important. The class 1, class 2, and class 2A and B and 3, which shows that strong recommendation and moderate and weak. It is based on the evidence available, which is level A, level B, and C and D. So the class of recommendation level of evidence which is available for that recommendation. So it does not imply that the recommendation is weak if it is level of evidence is C. And many important clinical questions addressed in this do not lend themselves to clinical trials. And there are some things I'm going to put it here, the good practice statements. And this is here the opinion of the task force experts in the light of when there is a limited data available for that particular question or no direct evidence available. So they think this is very important to put it across. So they will discuss and then come with a good practice statements. And this is 2025 guidelines. So I'm not going to discuss this. What I'm going to discuss is the COSTA, that is ILCOR guidelines. And also there are so many bodies which works with ILCOR. And I'm mainly discussing the ILCOR COSTA guidelines. But there are some that European guidelines, American Academy of Pediatrics, that is AAP and AHA guidelines also has come forward. But mainly I'm discussing the ILCOR COSTA guidelines. But whatever is different in the American Academy of Pediatrics, which is different because that is the one which has published the 9th edition of a neonatal resuscitation program. So I'm going to add few points for everyone to complete the process of updation. So here are the 2025 guidelines. This is AAP1. Also introduces a newborn chain of care, which addresses the overall context in which neonatal resuscitation occurs and how systems of care may impact newborn infant outcomes. So what does it do? So it includes not only at the time of resuscitation, it includes the chain includes right from the prevention, that includes the optimum care in delivery and recognition of the high-risk pregnancy and recognition of the labor, high-risk labor, and having the initial steps of resuscitation for all the newborns, ventilation, and includes advanced resuscitation, postnatal care, and up to recovery, because this is a complete process right from the prevention up to the recovery of these babies and the discharge. So as I will take you along through the basic resuscitation and I will take you to the advanced resuscitation. All of us know that anticipation and preparation is very important. So whenever we know that this baby is going to require resuscitation, it is very important to brief the neonatal team, obstetrics and midwifery team so that there is a resuscitation is going to happen. That's a good practice. And it is very important. It is stressed upon the importance of the teamwork. And whatever I put here in the box right side is what is different in the AAP recommendation. So I want you all to concentrate on the star which I have put it here. So it, as usual, it says that at least one person should be there who is trained in basic resuscitation for every delivery. And also, it is important for us to look at the risk factors, which is very important. And we should have a standard checklist when before the resuscitation, so that we need to ensure that the functions of the supplies and equipment are functioning. And this is an important, which is the definition. Many of these card management plans have been defined. It is time-based decisions, physiology-based decisions, and cord milking. They have defined in this guidelines very well. It says that the immediate cord care, when the cord is clamped within 15 seconds without initiation of respiratory support, early cord clamping when it is less than 60 seconds, and deferred cord clamping when it is equal to or more than 60 seconds. And this physiology-based definition decisions, it says that any time the cord clamp more than or equal to 60 seconds when the respiratory support is provided before cord clamping. And cord milking, this is intact umbilical cord milking, cut umbilical cord milking. This has been very well defined. So coming important update, that is cord management plan. So all of us know that those babies who are a term and late preterm, more than 34 weeks of gestation, who are vigorous, that means who cry at birth, so we are going to deferred clamping of the cord at or more than 60 seconds. So the recommendations have written in the pink words. Please look into that as well. In term and late preterm babies who do not cry at birth, so intact cord milking is preferred. Intact cord resuscitation for term and preterm babies, there is insufficient evidence to recommend either for or against intact cord resuscitation. This is an important slide which says that milking of the intact resuscitation, intact cord milking, and their outcomes. So umbilical cord management. So all preterm babies, so all preterms less than 37 weeks, when they do not need resuscitation, we are deferring cord clamping. Those babies less than 28 weeks, it is against cord milking. We should not be doing it. In those babies 28 to 36 weeks of gestation who do not breathe at birth, so umbilical cord milking is a reasonable alternative than the immediate cord clamping. This is a very important one, and it is very clear. And there are some conditions. There is insufficient evidence to make recommendations. That is either maternal, fetal, or placental conditions, and multiple fetuses, congenital malformations, placental abnormalities. In these conditions, there is insufficient evidence, so the decision has to be individualized based on the severity of the condition and maternal and neonatal risk factors. So for umbilical cord management, so this is what is there in the AAP. So it is nothing new. It is same, I have already covered. But what is there in the start, I want you all to concentrate. It is defined, the milking. So it is around 20 centimeters of cord from the placenta. The milk has to be done 3 to 4 times towards the placenta, towards the baby, allowing the cord to refill from the placenta each time. So here on the right side of the table, so the star one, for those babies 28 to 36 weeks of gestation who do not require immediate resuscitation and in whom deferred cord clamping cannot be performed, intact cord milking may be reasonable. They also say the same thing. It is nothing different. Coming to the temperature management. So all of us know there is a dose-responsive association between hypothermia and increased risk of morbidity and mortality. We all know that those babies more than 34 weeks of gestation, room temperature is to be, as per Costa, it is 23 degrees centigrade. If we want to take that for the Indian scenario, it is important to keep the delivery room temperature more than 25 degrees centigrade. And those babies who breathe at birth, skin to skin care and is with a parent immediately on the mother is very important when the baby is breathing at birth. For those babies who are preterm, less than 34 weeks, the room temperature more than 23 degrees centigrade as per the recommendation. For the Indian scenario, we want to keep more than 25 degrees centigrade. So it is important for us to monitor and manage the temperature so that we can avoid hypothermia and also hyperthermia. To prevent hypothermia, there are many things which we can use for preterm babies less than 34 weeks. That is, either we can use plastic bag or wrap, or we can use cap, or heated and humidified gases for respiratory support. And the skin to skin care may be helpful for maintaining normal temperature when few other effective measures are not available. So, but there is insufficient evidence for preterm babies. So here as well, nothing different here in AAP also, there is nothing different. But one point here they have mentioned here, for preterm infants, various combination of warming strategies or bundles can be used to prevent hypothermia in preterm babies. Now coming to the suctioning. So all of us know that, in the previous recommendation, and we used to do suctioning. So, here from 2010 onwards and in 2020, we do not routinely do suctioning of the pharynx, oropharynx. So we do suctioning only when the airway is obstructed or when you want to do positive pressure ventilation and you ensure that there is no secretions in the mouth and the throat. And so even in those babies who are meconium stained, born through the meconium stained amniotic fluid, it is against routine suctioning. Earlier, we used to do intubation and then do suctioning, and that is also not recommended now. And those babies who do not, even if the breathing is not regular, are absent or intermittent and shallow, we can do stimulation. Tactile stimulation is allowed only once. Now, coming to the heart rate assessment. All of us know that heart rate assessment is a critical indicator, and it shows us both the need and response to the resuscitation. And considered in the context, and always it mentions that, recommendation says that, always we have to take heart rate along with the tone and respiratory rate, not only heart rate alone. So if you are going to fix only on the heart rate and check the heart rate, and too few resuscitation interventions will be done. And how do we know? And this recommendation says that, how do you get the very accurate and very early heart rate assessment? That is possible with the ECG. But what in the places where the ECG is not available? ECG is not available and it is not functioning, where you can always use auscultation and pulse oximetry as the reasonable alternative for ECG. But what AAP, in the right side of the table, I want you to see the starred one. The AAP says that ECG should be used for the rapid and accurate assessment of the heart rate during chest compression for term and preterm. So they say, and it should be used for chest compression. Coming to the ventilation and oxygenation, that is an important changes in the new updates. So all of us know that we, in 2021 recommendation also, so T-piece resuscitator is recommended over self-inflating bag. But self-inflating bag should be available as a backup if there is any gas supply failure. And even in 2025 guidelines also, it shows the use of T-piece resuscitator over self-inflating bag. But it is important that we need to keep self-inflating bag. AAP recommendation, I want you to concentrate in this box, the starred one. It can be beneficial to use T-piece resuscitator instead of self-inflating bag with or without PEEP valve for administering ventilation for preterm babies. That is very important. Coming to CPAP versus positive pressure ventilation. In 2025 guideline, so we all agree that if the preterm baby has respiratory distress in the delivery room, we use CPAP. And that is preferred over tracheal intubation. And if I take in 2025 guidelines, this is regarding the preterms. What about late preterm and term babies? 4. So in these babies, we do not have sufficient evidence to urge for or against the routine use of CPAP for late preterm and term babies, possibly because of the high risk of pneumothorax. So this is what is there in the AAP recommendations, AAP ILCOR recommendation. I want you all to concentrate on the starred one. So here they have mentioned when we are giving positive pressure ventilation, the initial peak inflation pressure, they have written 20 to 30 centimeter of water is reasonable. And along with that, we can use PEEP as well. That has been recommended here, but not in ILCOR. And this is for the completion's sake, I've added this table, which has been mentioned in AAP textbook. That is, for the completion's sake, I have added. Earlier, we used to have the oxygen saturation target table started from 1 to 10 minutes of baby's life. But here, so there will be transient desaturation in the first minute of life, and there will be decreased oxygenation. Looking at that, we will not be able, or we should not be giving oxygen to those babies and predisposing those babies for hyperoxia when especially when the heart rate and the respiratory rate is normal. So intervene with oxygen only when the saturation remains pathologically low after initial stabilization steps, and we need to see the heart rate and the respiration and saturation, or as respiration and heart rate as well, to increase the saturation. What is different here in AAP is that they have started the oxygen saturation target from 2 minutes of life of baby's life. So sustained inflation during newborn resuscitation. We all know it is against the routine use of initial sustained inflation of more than 5 seconds. And a sustained inflation may be considered in research setting. It was there in 2020 guideline. For term and late preterm infants, it is not possible to recommend any specific duration for initial inflation due to very low, evidence. So now, positive pressure ventilation, this is there in AAP. So they say it is reasonable to provide the ventilation at a rate of 30 to 60. It is there only in the ILCOR of AAP, AHA, AAP. It is not there in the ILCOR, main ILCOR. And they have mentioned it is reasonable to initiate ventilation with an inflation time of 0.5 to 1 second in newborn infants. And they have mentioned ventilation corrective manuals can be useful when initial positive pressure inflations are not effective for newborn infants who require ventilation. What about the laryngeal mask airway or supraglottic airway? So the treatment 2022 recommendations say when the resources available, training permit, you can use laryngeal mask airway. May be used in the place of face mask for newborn more than 35 weeks of gestation, and we do not have evidence for those babies less than 34 weeks of gestation. We know that in the labor room, tracheal intubation is life-saving, but it is difficult and complex task. And this supraglottic airway device, SAD supraglottic airway device, it doesn't require any laryngoscope. And in those places where it is the back-end mask ventilation is not effective and they do not have the facility for intubation, they're not trained intubation, and it is very easy to use laryngeal mask airway or SAD. It is very easy, and there is nobody is recommending this over intubation. But in those places where not able to, the bag-end mask ventilation is not effective and they are not able to intubate, it's not successful, definitely you can use laryngeal mask airway, and it is very easy. And here, recommendation for interfaces, and please look at the box which starred one, where they use the laryngeal mask airway. Laryngeal mask airway when the face mask is unsuccessful, and they use as an alternative, as a primary method, the laryngeal mask airway usage. So now, the supraglottic airway device during chest compression. So now 2024 recommendation says for those with more than 34 weeks of gestation, chest compression with optimized PPV, and it is not recommended if the ET tube is only when the ET tube is not possible, unsuccessful, then you can use supraglottic airway device. It is reasonable. It is a good practice statement. What about medications? We do not have a sufficient evidence to justify. But there are animal studies which says that we can give adrenaline via catheter down the supraglottic airway device. What about exhaled CO2? When we are giving positive pressure ventilation, we are not sure whether the ET tube or whether my ventilation is effective. So in 20, what about using exhaled CO2 to know that my bag and mask ventilation or ET tube is in correct position? At 2023 recommendation, there is insufficient evidence for and against use of CO2, exhaled CO2 to guide non-invasive intermittent positive pressure ventilation using the interface, that is face mask or laryngeal mask airway or nasal cannulas. Then what about video assisted endotracheal intubation? So is it recommended? Do all facilities need video assisted intubation? So here is the evidence. But what 2025 guidelines says that so resources and training allow, only when resources and training allow, suggest use of laryngeal, the video laryngoscopy in comparison to traditional laryngoscopy, especially in settings where less experienced clinicians are intubating. But traditional laryngoscopy remains a reasonable option, as it has not shown any harm in using that. And a good practice statement is a traditional laryngoscope should always be available as a backup device if you are using video-assisted intubation or laryngoscopy. What about respiratory function monitoring in the resuscitation? There is no new studies were found to alter the current treatment recommendation. There is insufficient evidence to make recommendation for or against use of this respiratory function monitors in resuscitation. What about this? So we all know the cerebral regional saturation may be low, and that could be the risk factor for intraventricular hemorrhage. When the peripheral saturation of the baby is low, they wanted to know whether the cerebral regional saturation is low. They wanted to see, because that is risk factor for intraventricular hemorrhage. But 2025 guidelines says in newborns, infants receiving CPAP or positive pressure ventilation at birth, there is insufficient evidence to recommend for or against use of delivery of this NIRS for the regional cerebral oxygenation saturation monitoring. Now, another important thing, oxygen concentration. What is the difference? All of us know that those babies equal to or more than 35 weeks of gestation, when the baby needs positive pressure ventilation, we always use room air resuscitation or 21% FiO2. And also it is very clear now in 2025 recommendation that those babies less than 32 weeks, it is reasonable to begin resuscitation with equal to or more than 30% FiO2 and guide the saturation monitor under the guidance of the pulse oximeter. You can increase the FiO2. And what about those babies between 32 to 34? There is insufficient evidence to make a recommendation in ILCOR COSTAR. But here in AAP, I want you to concentrate on these two stars. They say that in preterm babies, 32 to 34 weeks of gestation and receiving respiratory support at birth, it may be reasonable to begin with 21 to 30% FiO2, they have mentioned. But here in ILCOR COSTA, they say it is insufficient. They have not made any recommendation. We are clear with the more than 35. We are clear with less than 32. But based on these recommendations, the people can use whatever is needed, but it is always with the pulse oximeter monitoring. But very important, the strong recommendation against the use of 100% oxygen was withdrawn in 2025 NLS COSTAR. It is planned to be reassessed later. What about chest compression? We do not have much changes in chest compression. So all of us know when the heart rate is less than 60, after the 30 seconds of effective positive pressure ventilation, preferably with the endotracheal tube, we go for chest compression if still the heart rate is less than 60. All of us know the same continues here as well. And the method, the place, the method of chest compression, and no, the ratio of chest compression, there is no change. It is same. And where it is given, the location, everything is same. There is no change. But here, what is different in AAP? That is expert opinion. It says during chest compression in neonates, the ventilation with endotracheal tube is recommended. And so when during chest compression for newborn, born at 34 weeks or more gestation, when placement of the endotracheal tube is not possible, you can use laryngeal mask airway. And in the right side table, I want you to concentrate on this recommendation by AAP-AHE. It may be reasonable to change the compressor roll every 2 to 5 minutes when providing chest compressions to the newborn infant, and the switch can happen because giving chest compression is really tiring. When they assess the heart rate, at that point the switch can happen. What about adrenaline? There is no change. The dose of adrenaline, the IV dose, endotracheal dose, and what is preferred, what we prefer is IV. So there is no change in that. Even here in AAP also, there is no change. But what is important for here to know, the earlier recommendation said that, so there is no urgent need of giving soda bicarbonate in during resuscitation in acute when the baby needs resuscitation. There is no need to keep that in the labor room, and when the baby needs prolonged resuscitation, that can be considered after shifting the baby to NICU. This is what we used to follow based on the previous recommendation. But here in 2025, and they have concluded there is neither direct nor indirect evidence to inform a treatment recommendation, that this treatment recommendation has been withdrawn and will be reconsidered later when the enough new evidence is available. And what is important, a recommendation in here now in 2025 is, post-resuscitation care. We know those babies are at risk or are having hypoxia, hypoxic ischemic encephalopathy. They are at more risk of having hypoglycemia or hyperglycemia. Those babies are at risk of having the worst outcomes when there is hypoglycemia. So it is important to monitor sugar values, and the goal is to avoid hypoglycemia or hyperglycemia. So it is, and who are those babies we need to monitor? The babies who are at risk of hypo or hyperglycemia are preterm babies, those babies who require chest compression, adrenaline, and those with HIE babies. And remember, the goal is to avoid hypo and hyperglycemia. We need to monitor those babies. What about blood volume expansion? Yes, it is same. But one important point I want you to remember. So we have done all the resuscitative steps, but correctly, there is no improvement. So if there is no routine use of volume expanders, but unless there is blood loss or there is history of any hemorrhage, and which are refractory to ventilation, chest compression, and medications. And one important thing they have mentioned in 2025 is that because blood loss may be occurred, a trial of volume administration may be considered in newborn infants who do not respond to resuscitation. You could consider even if the baby is not looking pale or in shock. So if all the measures of resuscitation steps failed, so because the blood loss may be occurred in neonates, you may not be able to see. So you could consider of all the efforts fail. It is a good practice statement. So it is same. The catheterization, umbilical catheterization, that is a primary method of vascularization, that is there no change. And either umbilical vein or intraosseous vein, that is no change. And even in outside the delivery room setting also, UVC or intraosseous can be tried. Okay. So now, so what about in the post-resuscitation care? So what has been recommended that, so we are doing all this. So no evidence that any specific duration of resuscitation consistently predicts mortality or moderate to severe neurodevelopmental impairment in which group of babies. So when the baby does not have heart rate and you have given all the resuscitation, all the steps correctly, still there is no heart rate. When can I stop? So it is reasonable time frame to consider this change in goals of care in around 20 minutes after the birth. So this starred one on the table, I want you all to concentrate on that. So that is very important. Then after so much of, we had regarding the therapeutic hypothermia. So we had a lot of, interest and debates happening. Do we have to recommend this in LMIC after all that, the publications? Yes, this also says in 2025 updated guideline. So it has revised all the evidences. Still after revising, it recommends that, 2024 treatment recommendations, and with the certainty of evidence, it is recommended. So it is recommended for those babies, that more than 37 weeks of gestation and term babies, and with evolving moderate to severe HIE in low and middle income countries in settings where a suitable level of supportive neonatal care is available. That is very, very important under the strict protocol. That is important, but there is no strict guidelines for late preterm babies, 34 to 36 weeks of gestation. It is not recommended because of insufficiency of the evidence. And this is for the completion's sake, I have added this table. And so this, the pressure, I want you all to concentrate on this, the rectangular one, the colored one, the last column. This is for the completion's sake. I've added this from the NRP 9th edition, AAP textbook. Here, the pressures, the more than 25, 32 weeks of gestation, less than 32 weeks, initial PIP, how much they set it up. And very important thing they mentioned. So what the recommendation is, when we give positive pressure ventilation, we assess the efficiency of positive pressure ventilation. We used to do that in 15 seconds. But here the new textbook says that, which is not there, not mentioned in the ILCOR guidelines. Now they say that you can wait. If the heart rate is not increasing, you can wait for 15 to 30 seconds, no problem, for after starting the ventilation. And if you do not observe chest movement, start the ventilation corrective steps. And what also has mentioned, there is no definite sequence of MR, SO, PA, which we are following now. And they say that, whatever you think is the mostly likely cause, prioritize the order in which you perform them is what is mentioned. And this I'm discussing this here only for the completion's sake. And this is also for the completion's sake. I have written here the ET sizing. So they have they have said that those babies less than 800 gamma, you could use 2 size endotracheal tube, and the way do we fix it? And this is again for the completion's sake. And this is tip to lip level. That is the middle of the anterior end of the maxilla. This is where you keep tip to, that is the tip to lip level, nasotracheal length. Okay. So this is, so now, so the evolution of Indian NRP guidelines. So earlier we had this book, the 4th edition by NNF India. And later, after 2 decades, we have been following the 8th edition. We have followed that for more than 2 decades. And later, 5-6 years back, we got the first IAP NNF neonatal resuscitation book, which is being currently across India has been used. And now, so the 3rd edition of manual has come up. Now we have introduced this, the 4th edition 2026 guideline, and we are in the process of bringing IAP NNF textbook of neonatal resuscitation. It is going to come soon. So now, so hope I have met the objectives of my presentation. And this is I've NRP updates. I've discussed the ILCOR systematic review and newborn chain of care, which is very important, not only at the time of resuscitation, right from the beginning in the pregnancy till the follow-up. We need to concentrate. We have discussed the cord management plan. We have discussed the ventilation and oxygenation, different ventilation devices, and use of respiratory function monitor. Is it really needed? And post resuscitation care of the babies we have discussed. And this is what I had to say. And I have given all the guidelines, which is I stopped sharing. I have given all the guidelines which has been there, which has been available. So it is up to us to use and what we need to modify for India, for low medical LMIC. So we cannot be using the same one which AAP says, okay, which European guideline says. That also has a different one. So we need to modify as per our available the facilities. So that's all I have to say. If you have any questions, maybe I'll ask Dr. Anup whether I can take any questions.
Dr. Ravi, Dr. Ravi is
Yeah,
the
yeah.
chair, ma'am. He can guide you. So maybe one or two questions because it's really wonderful, ma'am. 130, 140 odd participants listening to your talk and everyone's
Thank
stuck.
you very much for the opportunity given.
Dr. Ravi, please help ma'am to take the questions.
Dr. Chandrakala, this is one of the highest attendances. So I knew we have a star performer today.
Thank you very much for the opportunity. I really thank you.
Oh,
Are
thank
there
you,
any
Dr.
questions
Chantala.
in that? Thank you
Thank
very
you, Dr.
much, Dr.
Chantala, for
Ravi.
your very comprehensive and insightful talk. I am sure our audience would have benefited a lot, and because your talk was such insightful and comprehensive, I don't think so any question require for clarification. It was very comprehensively.
There are
So
questions.
thank
There
you
are
again
questions.
for talking.
Ravi, there are questions.
There are questions, but you have already answered, sir.
There
Okay,
are
now
one or
two
two.
questions. Two questions.
Two or
So,
three
Dr.
questions.
Chankala, if you can take one question, any guideline when SpO2 differences is still after 10 minutes, any changes or to see after 1 hour?
Actually, what is the guideline mentioned that only we have problem in peak of the saturation only in the first few minutes of life. So that is a time, we land up in giving oxygen and causing hyperoxia and oxygen-free radicals and all that. So whenever, during the first 10 minutes of life, please stick on to the guideline of oxygen saturation target table, which is there, 1 to 10 minutes of life. 1 minute, of course, now AAP says it is 2 minutes, but still 60 to 65 is there at 1 minute. But don't concentrate on the oxygen saturation when the heart rate is good and the respiration is good. Baby will have acrocyanosis, no need to worry. But 10 minutes later, definitely you will be able to get it through the pulse oximeter.
Dr. Chandrakala, you'll have to give brief answers because there are questions are cropping up. So give short answers so that we can jump into the next also. Yeah. So there was one question on whether DCC can be done in CCHD and Doppler changes with AEDF or REDF. Anything recommendation? Somebody was worried about congenital cyanotic heart disease or antenatally diagnosed Doppler changes. Should delayed cord clamping be done there also?
Yeah. So it should be individualized based on the condition, how severity it is. We need to individualize that.
So sorry to interrupt. We have other faculty waiting for the next case presentation. So Dr. Ravi, can you sum up, please?
Yeah. Yes, sir. I think do not require more or less there is a fine state, the fineness in all the clinical practice, which was an earlier recommendation. So there is a minor variation in this. Major variation is major thing. I think the cord clamping for 28 weeks to 36 weeks, whenever there is baby, do not require resuscitation. That is one of the change. And as far as SpO2 is concerned, now we do not need to worry. At 1 minute, we can see the saturation at 2 minutes, and I think residents are more stuck up in the ventilatory corrective steps. Now the recent guidelines has liberalized more that you can individualize yourself, whatever the sequence is not strictly what we learned earlier. So it is more a very user friendly kind of recommendation, I would say. So there are minor variation. I think there is not much deviation from. So and Dr. Chankala has already covered all these things. So I think now we can take over, Dr. Anup. Thank you so much for opportunity.
Thank you, Ravi. Thank you, Anup. Thank you, Dr. Chandrakala.
Thank you, Ravi. Thank you
Thank
so
you.
much. Thank you, ma'am. Thank you so much. It was really a wonderful presentation, enlightening, and truly, ma'am, thank you so much for coming to this platform of Delhi UN. Thanks a lot,
Thank you.
ma'am.
Thank you very much. Thank you.
So I will hand over to Dr. Shekhar Vishwas to introduce the chairpersons for the next presentation. Dr. Shekhar.
Yeah, thank you. And after such a nice presentation, let's have some case discussion. And the case is refractory hypoxemia masquerading as PPHN. And the chairpersons are Dr. Vidya Gupta, Senior Consultant Neonatologist, Head of Department, Department of Neonatology, Indraprastha Apollo Hospital, Delhi, and Dr. Chandan Kumar N, Senior Consultant Neonatologist, Kachi Gamakoti Child Trust Hospital, Chennai. So over to the chairpersons.
Uh, Dr. Vidya Gupta and Dr. Chandra. Huh? Chandra, sorry, we used your last designation at Kachi Kamakoti. You have moved on to Rainbow, it seems. Okay. so he just moved on to Rainbow, huh? Few months
Okay,
ago.
we should update it. Rainbow Hospital.
Dr. Vidya Gupta, ma'am.
Good evening, everybody. Can you hear me?
Yeah, please go
Yeah.
on.
Okay. Good evening, everybody. It is an honor today to chair this session. I would like to invite the case presentation as fast as possible because I think we're running short of time as it is. There's no need for me to say anything or really to introduce the people also. I think we should just go ahead and start off with it now. Please carry on.
Dr. Pankaj Garg is the moderator for the case, and he's a senior consultant and vice chairperson at Department of Neonatology at Gangaram Hospital. I would request the moderator to take over and proceed with the presentation. Dr. Pankaj Garg.
So, good evening, friends. It's heartening to see a lot of people attending the Zoom platform of Association of Neonatologists Delhi. We very recently, just 48 hours back, had a elaborate presentations on PPHN, which was at India Habitat Center, attended by many of the Delhi members. And today we'll be presenting one case which is of refractory hypoxemia, which we thought is persistent pulmonary hypertension of newborn. And then as we managed the patient, we found that this is something which is different from the usual PPHN. All of us know that portosystemic shunts are something which is seen in older kids with cirrhosis and with complications. But this child had something which we had not even thought of before the child presented to us. We have a very big multi-specialty team. We have Dr. Raghav Seth, who is a intervention radiologist with us, who is also one of our moderator. So welcome, Dr. Raghav. And we also have Dr. Mridul Agarwal. Dr. Mridul Agarwal is pediatric cardiologist with us. So it was the hard work of Dr. Mridul Agarwal to get this challenging case to us. And then as a multi-specialty team, we manage this case. So we have Dr. Sujay. Dr. Sujay is a very dynamic DNB neonatology fellow with us. He has just come from transporting a baby from outstation. He's just reached 10 minutes back to the unit and he's ready with his presentation. So I will request Dr. Sujay to make the presentation. Once we are done that, we will interact further. Over to Dr. Sujay for the presentation. Yeah, Sujay, you can take over. Yeah. Sujay, you are not audible yet. Have you not started speaking? You are not audible, Sujay.
Vijay, unmute yourself.
And he's already unmuted. I think there's some. Are you on Bluetooth? We cannot hear you.
Yes, he's on Bluetooth. Sujay, just remove that Bluetooth and go directly from phone. You are still on mute. You are still not being heard because you are on Bluetooth, it seems. Can you just stop using your Bluetooth?
You're not audible. But you're able to listen to us, is it? Sujay, say
You can
hands
nod
up.
your head. Nod your head.
Say
Yeah,
you're
he
able
can
to
listen
listen
to
to
us.
us.
He can listen to us. So you can remove your this and rejoin again if that is the case.
Okay.
You remove your
So,
this
yeah,
and
just remove this and start directly. Yeah, remove.
can
You're
you?
still not audible.
No, he is not sorry. He has not started speaking only. He just went off and now he will come join back again. Yeah. So meanwhile, you can just introduce Dr. Pankaj for the sake of time.
Right. So I think this case is otherwise looks like a routine case who came to us with severe hypoxemia. And as you know, the persistent pulmonary hypertension of newborn is one of the commonest reason of severe hypoxemia. And we manage this case as any other case with ventilation and with nitric oxide along with inotropes. But as we were doing that over a period of time, even once baby could be weaned from nitric oxide, we saw that
अभी
baby
सर
was still,
सर हो
yeah,
गया
yeah, not you're audible.
ऑडियो कनेक्टेड नहीं हो रही सर उसमें
Okay, now you're audible.
लॉग आउट करो दूसरे सिस्टम से कनेक्ट करो
No, you are audible. You are audible. Sujay, you can speak.
Acha, I think Anup is speaking to him. So, okay, so just stop sharing. I will share from my side.
writing Sujay, if my phone is audible, why you are not audible? Sir, even I am unable to.
No problem. I will start from my side. No problem.
Hello, sir.
Yeah.
Yeah, you are audible, Sujay, now.
Say something.
Hi, sir.
Yeah, yeah. Okay. Now you're audible. So I'll stop sharing. Now you can share.
Sure, sir.
Welcome, Sujoy.
Yeah. Share it now. Yeah, it's fine.
Sir, I'm audible now.
Yeah, yeah, you're audible. You can start now.
You able to speak now? Again?
Yes, sir. I'm able to speak.
Please, carry on.
So whether my screen is moving?
You just move it. You are in the first slide only. Mystery of severe hypoxia. Just move it. Go to next slide. Go to next slide. No. Yeah, something is happening.
Sujay, what I will do is I will share the presentation. You can say next. Okay.
Sure, sir.
Yeah, now it is there. You can start.
Yeah, please, Dr. Pankaj, please move kar lijiye ek baar.
Yeah. Start. It's moving.
Yeah.
Start now.
Today I'm discussing our case presentation. Mainly we will be having a overview regarding the case details, followed by investigations and detailed workup with imaging, and then the case management and the literature review. So next slide, please.
Yeah.
It's a baby of ABC. Baby was born on 24th of October and it got admitted on day 5 of life with us. And we actually transported the baby from Bareilly. It was a late preterm, 35 weeks, male baby. We presented to us with hypoxic respiratory failure with shock, and also baby was on inotropes. Antenatally, baby was born to a 33-year-old mother with gravida 2, para 1, living 1. And the living child was active and healthy, which was 3 years old, born to a non-consanguineous marriage. And antenatally, mother had the gestational hypothyroidism. Apart from that, there is no any history of GDM or PAH. GDM or PAH, and the level 2 scans and the fetal echo was normal in the baby. So next slide. And actually baby was born at Vatsalya Hospital, Bareilly. They did the LACS. The indication they mentioned was polyhydramnios, but actually the A5 was not known to us. The birth weight was 3,200 grams. Baby cried immediately after birth. The APGAR score was not available. And after that, the baby developed respiratory distress and they started the baby on delivery room CPAP. The course on day one, just immediately after shifting the baby to the NICU, they kept the baby on CPAP. They started the baby on IV fluid and also on antibiotics, piptas and amikacin. At 12 hours of life, baby's distress got increased, so the baby got intubated, and also they have given 1 dose of surfactant, and they continued the baby on SIMV, and in view of PCO2 retention, they went to the higher ventilatory mode, that is high HFOV, and baby also developed shock. So in view of that, they started the baby on dopamine and adrenaline. They got the 2D echo done, which was suggestive of PPHN. So in view of that, they started the baby on sildenafil, and they got the ultrasound abdomen, and they were having a suspicion that there was some anomalous connection in between the hepatic vein and also that of IVC. And one was there was a suspicion of infracardiac TAPVC. In view of that, they have referred the baby to our center SGRH on day of life 5. At the time of admission, the baby's heart rate was 168 per minute, BP was 56 upon 22 with 35 mean, CRT of more than 3 seconds with feeble peripheral pulses with RBS of 71 mg per deciliter, and on IV fluids with dopamine and adrenaline they have transported to us along with sildenafil. On examination, the antenna fontanelle was normal. There was no any facial dysmorphic features. Apart from that, on systemic examination also there was nothing more remarkable, and there was no any organomegaly, and baby was under sedation. So the provisional diagnosis was late preterm, 35 weeks with LGA. The weight was corresponding to 95th percentile with RDS, with baby has received 1 dose of surfactant with shock, and we kept the possibilities of sepsis, PPHN, congenital heart diseases, and also the IEM, inborn error of metabolism. The initial investigations we have got was on day of life 5. The CBC was of 15 grams per deciliter with platelet count of 59,000 with TLC of 3140 and ANC of 1256. CRP was positive, which was 40 mg per liter. Ammonia was 74.8 micromoles per liter. And initially also we noticed that the direct bilirubin was on the higher end, that is 3 mg per deciliter. With SGOT and SGPT was in the borderline normal ranges. So next slide, please. And we continued the baby on initially on SIMV, and again we shifted into the HFOV. In view of PPHN, we started the baby on INO and also on VASO, and we continued the adrenaline support. And after getting all the blood workup and all, blood CSF workup and all, we started the baby on meropenem and colistin. We got the 2D echo done. We showed PDA of 3 mm with dilated RA and RV with moderate TR with pressure gradient of 80 mmHg with TAPC of 6 mm with severe pH. Even in the subcostal weave, we got a doubt that there was a dilated portal vein trunk which was draining into the IVC. On day of like 6, on the very next day, we got the ultrasound abdomen done. which showed that there was a patent ductus venosus with the main portal vein, which was opening into the IVC with non-visualized intrahepatic portal vein. And in the next slide, here we are showing in the left side, we are showing the static image with the yellow arrow shows the portal vein, and whereas the red arrow shows the patent ductus venosus, and also the blue arrow, there is a common channel which is forming from the portal vein and also the duct, patent ductus venosus into the common duct, which in turn is started draining into the IVC. The white arrow shows the aorta. In the next image, that is the video one, which shows the same. Once again, I am able to say to you, there is a white arrow which is showing the aorta. The same has been depicted in the video image also. And also there is a common channel. We had a suspicion and it was found in the ultrasound also, which is draining the portal vein and also the patent ductus venosus. And in view of direct hyperbilirubinemia, we, we ruled out the other causes of direct bili. Urine CMB PCR was negative. The TSH and free T4 levels were normal, and TMS and also the galactose estimation we got it done, and both were normal. And regarding PPHN, we were able to taper and stop INO by day 8 of life, and also by day of life 13 were able to taper vasopressin and also the adrenaline, and we stopped it. On day of life 11, we are able to wean the baby from HFOV to SIMV. So on the very same day, we got the CT angiography done, in which we were able to see. I've already labeled the image. There is a ductus venosus and also the portal vein, which is draining into the common channel, and in turn it started draining into the IVC, which we can see in the left side of the first image.
So,
And in the
Dr.
right
Sujay,
side,
we can request Dr. Mridul Agarwal to or and Dr. Raghav to make a comment here before we proceed further. Dr. Mridul, will you like to comment here?
Yeah, so we have discussed a little bit of about this, that there is a communication between portal system and IVC, and fetal, like we do a lot of fetal echocardiography. Fetal wise, whenever this portal communication is not at the hepatic confluence, we never level that communication as a ductus venosus. So we call these thing absent ductus venosus because that communication is not there. And most of the time, portal system, ductus venosus is a restrictive tube. And whenever there's a large communication, ductus venosus anyway will not develop because a restrictive system cannot develop whenever there is a large communication between IVC and the portal system. So although it is shown there, I cannot be very say with very confidence that it is that thing. Other thing is there's communication between portal system and IVC, and whenever there's hypothesis that liver metabolizes most of the endothelins and the serotonin. So whenever liver portal flow is less, then serotonins and the endothelins are not metabolized well. And maybe that is not causative, but definitely contributory to this PPHN. So PPHN has started, but because of decreased portal metabolism, this PPHN has worsened because there is decreased hepatic metabolism of these vasoconstrictors.
Okay. So we can go back to Dr. Sujay.
that's the next slide.
You can comment on this also, Dr. Mridul, on the CT NG report. Yeah, yes. Okay, Sujay, you can say.
In this image, we can see there is an hyperplasia of the hepatic artery on the left side of the image. On the right side, the second image, which also shows there is a formation of a superior hepatic artery from the superior mesenteric artery and also the splenic. There we can see the hyperplasia, which is a compensatory thing because there is a reduced blood supply because of the Abernethy malformation to the liver. 。 . 。 。 。 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 。 .
Yeah, so
And in the same CT angio, then we were able to find out that there is a big lung abscess which is on the right side of the image. There we were able to see the lung abscess, and on the left side this is the gallbladder, and we were able to make out there's a prominent cystic duct which is also seen. Next image. In the CT angio, that there was a communication of the portal vein and also ductus venosum through the common shunt into the IVC, suggesting the possibility of Abernethy malformation type 1B or type 2. And also there was a stenosis which was seen at the ostium of the left inferior pulmonary vein. And there was a cavitating lesion with air fluid levels in the anterior segment of the right upper lobe, which is likely the abscess. And also there was a hypodense area in the peripheral with the peripheral enhancement, especially in the segment of 4 and 5 of the liver, which are the infarcts which are mainly seen in the Abernethy malformation. For the lung abscess, with the help of our IR team, we were able to aspirate that. Then we added empirically vancomycin. Then the culture turned out to be Klebsiella pneumonia and Enterobacter armouchiae, which was sensitive to minocycline, cotrimoxazole, and also the colistin.
So, Dr. Sujay, Dr. Raghav here. Dr. Raghav is our intervention radiologist. So, he was the one who was. So you have to see is a newborn, just 3 kg, and doing a lung abscess through a intervention procedure is challenging. So, we'll request Dr. Raghav to make a comment here.
Yes, sir, sure. So, like Dr. Sujoy just showed, lung abscess was actually a small abscess, but since it was peripheral based, so we were fortunate enough to diagnose it and to visualize it completely on high resolution ultrasound. So, using the hockey stick probe and under mild sedation, I could, of course, under local anesthesia as well. So, I could aspirate completely the content, the purulent part, and it was frank pus indeed, and it proved out to be positive for these organisms. So initially we thought that yes, this will help, but let's see, Dr. Sujay will just unfold the story.
Yeah, go ahead, Sujay.
Next slides. Then in view of the significantly elevated liver enzymes, which we can see on day of life 16 also, we repeated the LFT which showed direct billy of 2.97 on day 24 of life. Again, we were able to evaluate the direct billy was 4.99 and the SGOT and SGPT were on the higher side only. As we were able to find out that the minocycline causes hepatotoxicity, then we stopped the same drug. Then we started the baby on cotrimoxazole, and we were able to complete 4 weeks of IV antibiotics for the lung abscess. Regarding ventilation on day of life 21, we were able to wean the baby to NIMV, then to CPAP. Then on day 28 of life, regarding the recovery of lung abscess, we repeated the HRCT, which revealed us the pneumothorax, and in turn we got the ICD insertion also. Then the baby did well. Throughout the stay, baby's ammonia levels were normal. Initially on day of life 5, the baby's it was 74, 78, and also 100 it came up. Then once we stopped the drug also, still on day of life 29, again the direct bilirubin persistently started increasing with SGOT and SGPT kept on increasing, and hence we got the repeat ultrasound done in view of whether there is any formation of new lung abscess or what, which actually revealed there is a multiple small foci which is seen on the periphery of the liver, especially on the right lobe of the liver in the segmental area, but there was no any evidence of liver abscess as such. And apart from that, so in view of this, with because of the persistent on the oxygen support and also the elevated liver enzymes as the day increases, then we take a decision for endovascular device occlusion.
So, I think now again we can request Dr. Raghav to make a comment that how they do it, the procedure, and how difficult it was to do it in this patient. Dr. Raghav?
Yes, sir, sure. So it was a slightly difficult procedure, I will say, but yes, we got good results, and I will just explain the procedure in brief. So for this neonate, we first punctured the IJV. So we took both bilateral IJV accesses. So of course I cannot show you with the pointer, but on this left image, so what I have done here is I have cannulated the IVC and from the right jugular axis, and we have just taken a venogram here. So we can just we wanted to prove that the IVC is patent and there is no abnormality. Then in the second image, the metallic marker which you can see was I placed it here on live using live ultrasound guidance at the point where the shunt was seen, where the Abernethy malformation was there, so that I could understand where at which point I have to cannulate. So next image, sir. So with the help of that, this is actually the catheter which you are seeing. So this tubular structure is the catheter. It was a 4 French catheter, and finally we could cannulate this from IVC directly into the portal vein. So that itself proves the direct communication or the Abernethy malformation. And now this structure in all these three images is actually the portal vein, which is not yet developed fully, and we are not able to see the SMV or splenic vein because the flow is so rapid towards the IVC that the contrast is not going into the splenic SMV. The direction is from portal to systemic as it is expected. So these are just the oblique views. The right two images are the oblique views. Then what I did, we took left jugular axis also, because from one of the jugular axes I entered into the splenic vein, and that is the left-sided image, and through the other jugular, that is the left jugular axis, again through the same tract, entered into the SMV, so that we have two safe accesses. So now you can see the left one is the splenic vein and the right image is the SMV. And when we are taking on the right image, when we are taking the contrast, and we can see from the SMV contrast is coming into portal and then directly into IVC and the heart. So that is the shunt. So next slide, sir. So then finally, actually this is just shown in summary. Then next, from one of the jugular accesses, we took this VSD occlusion device because none of the plugs were small enough to be used in this place. So we used a VSD occlusion device, which is shown with this red arrow, and we placed it exactly from one of the jugular axis within the shunt. And actually, when it was placed, we took the third femoral vein axis also to inflate a balloon in the IVC so that the this VSD occlusion device does not fall back into the IVC. And then the right side image is showing the confirmatory run, showing that this plug is only occluding the Abernethy malformation and there is no occlusion in the IVC flow.
Thank you, Dr. Raghav.
Thank you, sir.
Sujay.
Then on day of life 35, we're able to wean the baby to the room air, and LFT gradually started improving on day of life 40. Before discharge, the irritability has decreased to 6.8, with SGOT and XGPT also started decreasing trend. Regarding the literature review, this Abernethy malformation is a congenital extrahepatic portosystemic shunt. It's a rare disorder where a portal blood which will bypass the liver and drains directly into the systemic circulation, which was first described by John Abernethy in 1793. It's an extremely uncommon anomaly with an undetermined prevalence, and the cases of started rising in the past decade, mainly due to the enhanced imaging methods and also the greater awareness regarding the Abernethy malformation. Regarding the portal vein embryology, in the embryo, the right and left vitelline veins will emerge from the yolk sac. Approximately at 4 weeks, the communications will develop in between the veins, and they will in turn anastomose with each other to form a figure of 8 around the developing duodenum. In this image, in the image A, we can see there is a right vitelline vein and also the left vitelline vein. There are three anastomoses in between each other. Then gradually the right umbilical vein will disappear, and among these anastomoses, again the cranial ventral anastomosis will persist, whereas the caudal ventral anastomosis will disappear, then leading to the formation of portal vein, that is mainly from the superior mesenteric vein and also from the splenic vein. Then in turn this portal vein will split into the right portal vein and also the left portal vein. Then this left portal vein will in turn will join the ductus venosus, in turn leading to the drainage into the IVC. Regarding the classification of Abernethy, there is complete and also there is an incomplete. In case of a complete, there is an end to side with absent intrahepatic portal vein branches. And whereas in case of an incomplete, there is an intrahepatic portal vein radicals are present in this. I will explain in the next image. Here in the first top corner image, which is a normal thing where the splenic vein and supramesenteric vein will in turn form into the formation of the portal vein. Whereas in case of type 1A, there will be no formation of portal vein. Both of them will directly join into the IVC. Whereas in case of type 1B, there will be a formation of extrahepatic portal vein which drains into the IVC directly without any passage through the liver. Whereas in case of type 2, there will be a formation of portal vein, but there is a direct shunt between the portal vein and also the IVC, which is an extrahepatic in nature. And in our baby, we found out to have a type 2. In coming to the clinical features, there are three types, mainly with the features which are relating to the shunting of portal blood and also features relating to the because of the secondary congenital abnormalities which are associated with it, and also due to the secondary hepatic lesions. So next slide, please. These are symptoms which are related to the shunt, mainly the hepatopulmonary syndrome, and in which there is exists a triad, in which there will be arterial deoxygenation also. So previous slide.
Yeah, I have in the previous slide now. Yeah, this is the one you want to see? Go ahead, Sujay. I think Sujay has lost the connection. So let me just match up here. So symptoms are related to the shunt like hepatopulmonary because ultimately the liver function is bypassed where the portal venous blood is directly going into the systemic circulation. So liver is not able to act, and that is why you have the liver dysfunction. And that is another reason that even the hepatic artery, there's more lot of aneurysm formation and new vessel formation. So that leads to hyperammonemia, galactosemia, pulmonary hypertension, and neurological symptoms because of toxins like ammonia and manganese. So onset of hepatic encephalopathy can be very early as 18 months, and type 1 will not be corrected till you do liver transplantation. But type 2 can be still corrected by the shunt, which we just shown. So I think features are maybe secondary to some other congenital anomalies also. So fortunately in this baby, we could not find any other anomaly, and it was a pure Abernethy. But if you look at the literature, there are a lot of features which are secondary to hepatic lesions, shown that you may have hepatic adenomas, even hepatocellular carcinoma, hepatoblastomas. All of these are common in these patients who remain untreated. So this child, we had the possibility of type 2 is more common because here we could see a shunt. Though they present late, but this patient presented very early, and it required intervention right in the neonatal period by our interventional advances. So this is how it was done. So that shows the anatomy which is there and how it gets changed. If you have no blood going to the liver, then the hepatic arteries, they start getting more. Because of hypoxemia, there's hypertrophy of the hepatic arteries. So I think this will summarize what we are trying to say, that in the therapeutic algorithm because of portosystemic encephalopathy, liver dysfunction, and shunt ratio being high. If it is high, then definitely we know they will have a very florid presentation. Type 1 will require transplantation. Type 2 will require closure of shunt, which we did in our patient. And these patients can get into liver tumors also. So how to follow these babies? This child is still in our follow-up. Is showing we have to take care of growth, neurodevelopment, encephalopathy. Liver test and ammonia have to be done regularly, and even alpha fetoprotein. In this child, even alpha fetoprotein is still raised, and we know that these children still can develop hepatic adenomas, hepatocellular carcinoma, nodal hyperplasia. So that is why they need to be followed very diligently. So this is what endovascular is done, that you do Doppler ultrasound. So Dr. Raghav, we can come to you again. You did a Doppler ultrasound in this patient on follow-up. Can you mention that?
Yes, sir. So after 2 months, I think 2 months of follow-up, I did ultrasound just a couple of weeks ago. And yes, the flow is still there in the shunt, partial flow is there, but the child has improved tremendously, clinically also in terms of LFT, lab parameters also. And radiologically, the change was what we could see on Doppler, that now the portal flow has started coming, the portal veins have developed further, and flow is direct exactly hepatopetal, which we expect, and it is even going more towards the periphery. So that is what the main target is. And the second important concern that we had, that by chance there should be no stenosis or occlusion, even partial occlusion of the IVC. So that was also well taken care of. IVC flow was completely normal. So this partial flow which is still there in the shunt, it will take time to get occluded. It is actually a slow process, and after 1 more month, that is 3 months after the procedure, we are planning a dynamic contrast enhanced MR, and we are going to repeat ultrasound every 3 months for this child.
So fortunately, we followed up this baby after some time. Now the baby is 6 kg. He got admitted with bronchiolitis. At that time, we did investigations. His bilirubin has almost come down to normal, 1.5 direct. OTPTs are also normal. Ammonias are still normal. The alpha fetoprotein is still raised. So that is what we have seen in this baby. Thank you so much. I'll stop sharing here. So, but basically, if I want to summarize, as Dr. Sujay has been, he's out. So, we had a patient who was delivered because of polyhydramnios, and it was typically looked like a case of PPH until that time. On an incidental finding on ultrasound suggested it may be obstructive infracardiac, infradiaphragmatic TAPVC, and that is how our pediatric cardiology team, Dr. Mridul, came into action, and he said that it's better to be shifted to our place. We transported this baby to our place, and then it was diagnosed that this is not infradiaphragmatic obstructive TAPVC. It is Abernethy malformation in the liver, where portal vein was directly going into the IVC. There was a shunt. So we first managed the child from PPHN lines. Incidentally, it was very difficult diagnosis for us, but then we were more worried about taking care of PPHN part initially. Baby got its share of sepsis also, which we recovered. Then baby got a lung abscess. With the help of Dr. Raghav, IR team, we could drain that. He had a pneumothorax. Again, with the help of IR team, we drained the pneumothorax. And as everything was getting out, INO was weaned off, antibiotics were stopped, and then we realized that his liver functions were getting deranged. We thought maybe it is because of minocycline. We stopped the minocycline, still liver dysfunction was going up. And then we thought there's no way, we have to manage the Abernethy also in this neonatal period only. We debated whether it
I
needs.
think Dr. Pankaj, I think Chandra and Dr. Vidya, Chandra is, he has come graciously because despite his daughter's exam
Right.
problem, he
So
can try
over
just
to Dr.
because
Chandra for comments.
he can summarize, and Chandra
Sure.
and Dr. Vidya Gupta can
Sure.
certainly summarize and do things.
Yeah, good evening, everyone. Thanks, NNF Delhi, for this opportunity. And it's a quite interesting case and well managed by the teamwork of the clinicians. Um, I have few questions. After that, probably I will conclude with my comment. So polyhydramnios, like how severe it was. I mean, do we have any AFI,
So we don't
anything?
have an A5 value, but because patient got referred to us, they said the indication of LSCS was polyhydramnios, but it was not
Okay.
quantified in the reports.
Okay. And do you have any X-rays? I think I don't know whether I missed any X-rays in the presentation.
So at the time of birth or later on?
I mean, maybe
We did
at the
not
time of
show
birth.
we did not
Okay.
show any X-rays, but that X-rays were not showing suggestive of any lung disease per se. Though we did give surfactant, but parenchymal lung disease was not very evident on the X-ray. But later on, baby developed lung abscess and then pneumothorax. So we had a lot of X-rays of this baby.
Okay. So in the retrospect, it looks like PPHN was an isolated entity, and this Abernethy malformation causing liver dysfunction was a separate entity, right? So PPHN probably was due to the late preterm birth, and then probably there was some RDS could have been there, which resulted in some form of hypoxic respiratory failure. And even before you correcting the Abernethy malformation, I think PPHN started improving, right?
Correct.
Yeah.
But with the help
Yeah.
of very prolonged use of nitric oxide.
Yes. Yeah. So even though, I mean, as explained by our cardiologist, that this shunt could, precipitate or worsen PPHN. Well, as a neonatologist, I would say that, the PPHN component was basically probably was a secondary PPHN, primarily due to a lung issue, which may be due to the late preterm birth and resultant surfactant deficiency, which has recently kind of responded well to the treatment. Of course, the presence of sepsis, lung abscess could have resulted in a deferred, slow response to the treatment, but eventually the clinical team was successful in getting the baby out of INO. And this Abernethy malformation is quite interesting to know. I have seen a couple of cases of portosystemic shunt, but they were all asymptomatic. I mean, it did not require any kind of intervention. But I can recall during my DM training in AIMS, that time we had one case which presented with conjugated hyperbilirubinemia and all that. Okay, it was quite interesting to know that this malformation can present clinically due to different pathophysiologies. So this direct hyperbilirubinemia, if student is available, can we have some interaction with
I
the
think
student?
he logged out somehow. I think maybe.
Okay.
But
Okay, maybe just I wanted to ask him some questions so that it will be
we are
useful for
also students. You
students.
can ask me.
So, I mean, how do we explain this, direct hyperbilirubinemia?
Right. I think we reviewed the literature because, as you are saying, Abernethy is not something which we see day in and day out. I have also seen two asymptomatic Abernethy before. And once we looked at the literature, it shows that hypermonemia and cholestatic jaundice related to liver dysfunction is common features which is seen in Abernethy. And ultimately, they also developed hepatic adenomas, hepatoblastoma, hepatic cellular carcinoma 5. So all that was mentioned.
Okay.
That is why initially we were hesitant to attribute cholestasis to Abernethy because
Okay.
ammonias were always normal. So we were restricted for other causes of cholestasis also. But as no other reason was found, even antibiotics we stopped. Minocycline can cause cholestasis. We stopped that. Despite that, coming off ventilator, but nothing else attributable. Then we attributed this to Abernethy, and then once we intervened. Now, retrospectively, we know that as we took care of the Abernethy malformation, the liver functions became normal, cholestasis became all right, and so retrospectively, definitely, it looks like that cholestasis was because of this Abernethy syndrome.
Okay.
Dr. Vidya, ma'am.
Thank you very much,
Yeah.
Dr. Pankaj.
No, thank you so much, Dr. Pankaj, for a very interesting case. The lung issues, particularly the abscess, is not really part of Abernethy, is it?
So we reviewed the literature, ma'am. They say that because it is gut, is the blood flow is bypassed. It is
Yes.
going through liver. it is going bypass through the intersystemic circulation, they are more predisposed to these infections, uncommon
but,
infections.
but it's not necessarily part of it.
It's not necessarily part, but
Nor is the
maybe.
polyhydramnios.
Yeah. So we thought maybe this baby has got lung abscess because ongoing infection, and which was partly contributed by Abernathy, but may not be the only one. So we are also joined by Dr. Neeraj Agarwal, our senior pediatric cardiologist. Yeah, thank you, Dr. Neeraj, for joining.
Thank you.
Sir, I have few comments on this
Yeah.
presentation. Unfortunately, I don't have a student today, but like Dr. Pankaj sir, we had one more patient yesterday also. The message from this presentation should be, whenever you have PPHN case, resistant PPHN case, look for abdomen and look for cranium. Look for extra cardiac malformations to cause PH. One of them is Abernathy, the other one is cranial AVN. So all the students who are around seeing the PPHN, resistant PPHN, don't forget these two areas to be screened out. They all have to be screened out in all PPHN cases. Then, like vertical channel was seen by in the periphery coming to IVC. How do I confirm it that is it TAPVC or not? As we all understand, infracardiac TAPVC is a difficult diagnosis to make. Lot of cardiologists will miss the infracardiac diagnosis. Any clue, any student is around who has a clue how to pick up infracardiac TAPVC without echo? Like this patient has a vertical channel. How can I pick up infracardiac TAPVC without echo?
Are they usually obstructive?
Blood gas, VBG, showing that blood gas in that can tell you.
Yeah, mostly see what we learned, Dr. Pankaj sir, long time back. We published the article also. See, what is happening is pulmonary veins are draining via vertical vein to the liver and ultimately goes to the IVC. If you have a catheter placed in IVC, the saturation of this sample, umbilical vein near the IVC RA junction, would be 99%, because pulmonary veins are highly saturated. So in all the forums, I say, whenever you're suspecting infracardiac TAPVC and not sure, confirm this by umbilical venous sample, which is catheter placed between umbilical vein to IVC RA junction. Because whatever the situation, if the pulmonary veins have highest saturation on the body, and if they're coming to the liver, they are draining into RA by IVC, you will get the highest saturation in the umbilical vein. So in such situations, I would recommend to have a umbilical vein to IVC catheter and get the gas. And if that is showing saturation 95, 97, that pulmonary vein is coming there. That is my second message from this case, learning point. And third thing, fetal diagnosis is possible. Nowadays, level 2 should pick up this diagnosis. And if not level 2, echocardiography should pick up. That is easy to pick up diagnosis nowadays.
Right.
So this is possible nowadays. Though I understand the limitations, but now you should, whenever you're doing level 2 scan, ask for them to demonstrate ductus venosus, umbilical vein, pulmonary vein. They're easy to pick up nowadays. So that is a way forward for us to not to go into this channel debate after birth, and you should pick up before birth.
Thank
so
you.
the three messages from my side.
Thank you so much, Dr. Neeraj.
Thank you.
Any other, Dr. Midul, you want to comment?
This anomaly of Abernathy has very few reports with neonatal PPHN, and actually it's always questioned that whether it is causes PH or not, because even in adult, only 5 to 10% cases of Abernathy present with pulmonary hypertension. So mechanism-wise, very difficult to prove because most of the mediators are not produced by liver of pulmonary hypertension. Then, like I said, but cleared by liver. So that can be attributary to the pulmonary hypertension prolongation rather than the cause of PPHN. So it cannot be, we cannot, even with this case also, we cannot call that this has caused a PPHN. The patient has a lot of other contributory infection, other things were there. So most likely that has caused a PPHN, but this has caused a refractory PPHN because their mediators were not cleared. So once we are able to control the sepsis, we are able to manage the pH, then this balance has been restored. And then even without the closure of Abernathy, even before closure of Abernathy, we were able to get the baby out of ventilator, out of INO and everything. So that's how it can be explained with Abernathy and PPHN, that correlation.
Yeah. So thank you so much. I think any comments or questions
Dr.
from
Monica,
the
Dr. Monica Kaushal has joined from Middle East, from Gulf. I'm so thankful. Dr. Monica, what is your experience in, because Dr. Pankaj is asking comments, have you seen such
No.
malformation in your part? You're not heard? Yeah, it's
I,
down there.
no, I have not seen, but yeah, but what Dr. Neeraj has said was we have seen many that we have different causes of PPHN, like we had one coarctation of aorta which was missed, and it is difficult to see initially, and also one we had this AV malformation. So we do see those cases which are behave like PPHN, but the causes are different.
Okay.
So that message is very important for everyone to
Neeraj, right?
get. Yeah. But
Thank
this
you.
type of case we have not seen. Yeah, so the subdiaphragmatic, those, yes, difficult ones. Also, we have missed. Our pediatric cardiologists have missed initially, and sometimes it becomes a little bit late to actually diagnose those cases. But I wasn't knowing this new thing about doing a blood gas at that level to get the saturations high. This was something
Neeraj,
new.
you've given now even me
Yeah.
the confidence of diagnosing infracardiac
Yeah.
So
TPVC.
I will add one more thing, ma'am.
Yeah, it
Dr.
was
Monica,
a
That was
great
very,
ma'am,
very
learning point.
interesting.
It
Well
was a
done,
Dr.
great
Dr.
Monica,
learning
Neeraj.
ma'am,
point.
Dr. Bish,
Yeah.
one case report is there from our unit. You can search for that case report.
Okay.
Okay.
Thank
That
you
was a
so
nice.
much.
So, sorry
So
to
I think
interrupt.
now we over to Dr. Anup Thakur
Yeah, yeah,
from
yeah.
her side. Yeah.
Sorry. So, so I think, Dr. Chandra, should I conclude? I mean, it's
Yeah,
fine.
yeah,
You want
yeah.
to,
Fine. Yeah, yeah, yeah. No more
Madam is over.
questions.
Dr. Vidya, ma'am?
No, I think that blood gas thing was very, very interesting. That was
Yeah,
well
very
done. And
useful.
thank you for
He's
a
Very
told
very,
us
useful
very
so.
point.
interesting case report,
Yes.
Dr. Pankaj. So that was very well done.
Thank you, ma'am. Thank you so much.
Must
Thank
congratulate
you.
you for it.
Thank you, ma'am.
Thank you, Dr. Pankaj and the
So,
team. Okay.
so thank you all the chairpersons, Vidya ma'am, Dr. Chandra, pitching in despite such a busy schedule and despite having exam of your daughter. So thank you so much for coming on the Delhi AON platform and enlightening us. And I would really like to thank the moderators, Dr. Pankaj Garg, Dr. Mithil, and Dr. Raghav. And Dr. Pankaj, especially because he shouldered this case despite Sujoy not being able to join. So he was acting both as a moderator and a presenter, as a student and a teacher both. So thank you, Dr. Pankaj, for smoothing the edges in a very, really wonderful way.
Thanks, Pankaj. Thank great.
And I would like to conclude the meeting with a vote of thanks to all the participants who had joined. And thank you, President Dr. Surendra Vish, sir, for being throughout from the beginning to the end. It was really wonderful to have you as well. And all the EBOB members who have been there, all the participants.
Vivek, I think I see so many of them today.
Yeah, yeah.
I'm really
So
thankful to all of you.
really been great. And just an announcement that we are conducting an advanced NRP provider course by ON on 1st of March in Fortis Hospital, Salimar Bagh. So we have already shot the flyers in various groups. So I would request the various institutes to kindly ask their fellows and residents to register for the course. So thank you once again, and good night, all of you. God bless everyone. Thank you.
Thank you.
Thank you.